Extrauterine infections, therefore, include infected hematomas, true abscesses. There can be cellulitis. There often can be an infection at the region of the incision, which can extend elsewhere. And the frequency and severity of these infections are significantly greater after cesarean section compared to vaginal deliveries. This patient had a history of chorioamnionitis and failure to progress at 41 weeks gestation, requiring a cesarean section. She came with fever, and these are the CT images. In the sagittal reformat, again, you can see where the cesarean section scar is, only a small amount of hematoma in the bladder flap region. But if you notice, this is a transverse view higher up, the aorta, inferior vena cava, and this is the right ovarian vein. It's dilated, and there's a central area of hypodensity. This is a coronal reformat, the inferior vena cava and its branches, and this is the ovarian vein coming towards it. And again, you can see this low density material. This patient has a septic thrombophlebitis of the right ovarian vein. In addition, you may have noticed a small high-density focus here at the endometrium junctional zone that was retained products of conception. This sonogram was performed in a patient with unexplained postpartum fever. The uterus is still a bit enlarged, perhaps a little too large for this stage. There's a little bit of complex fluid in the endometrial cavity, but nothing terribly unusual. In the right adnexal region, however, separate from the ovary, which is down here, we could see this little round echogenic structure with a cystic center, and this is a transverse view of one of the ovarian veins filled with thrombus. Other vessels in this area do have flow. The CT was performed for confirmation, and so you can see the right ovary, and here's the little vessel with the bright enhancing wall and the low density center, and you can see on the lower image as well. These are much more difficult to see sonographically than they are on CT, but if you know what to look for, you may be able to figure it out. The right ovarian vein should be close to the ovary. Other patients sometimes show diffuse septic pelvic thrombophlebitis in any number of the veins in the pelvis, and they look like these little Cheerios, these little echogenic round structures with low density centers. In contrast, here's the external iliac artery and vein, and this vein is completely and normally enhancing. These veins have thrombi in them, and you can see them here as well. In addition, you might notice that this patient had a breakdown of the incision and herniation of the enlarged uterus at the site. Septic pelvic thrombophlebitis occurs at least probably in 1 out of 600 deliveries in the United States, though possibly underestimated. It is commonly unilateral, for some reason the right more than the left, and the thrombus in the right ovarian vein can extend to and even higher in the inferior vena cava. CT and MR have become the techniques of choice. It is more difficult to appreciate on ultrasound, but if this is the only modality available or appropriate for the patient, you can use it. Findings include the enlarged ovarian and other pelvic veins with low density thrombus. Often the vessel wall is enhancing or inflamed in appearance, and there also may be adjacent inflammation in the surrounding fat. Now we'll turn to chronic complications following cesarean section. So these are patients well out of the immediate postoperative time period. We'll look at what the scar looks like long-term after cesarean section on both ultrasound and CT, and then a variety of issues related to that scar. In some patients, for whatever reason, the adhesions and scarring can cause significant distortion in the position of the uterus. Because of the tethering of the anterior uterus to the anterior abdominal wall, the cervix becomes elongated and the lower uterus is stuck there. Transvaginal imaging, therefore, allows an excellent visualization of the cervix, but often the body of the uterus is somewhat out of the plane and far from the transducer and difficult to visualize. Unfortunately, in this situation, transabdominal imaging is also limited because the distended bladder will no longer serve as a sonographic window. In this situation, our recommendation is to try a higher frequency transabdominal transducer to see the body of the uterus, assuming that the patient's body habitus permits. So let's take a look at this. Here is transabdominal images of the uterus in a patient with a history of prior cesarean section. This is a transverse view and a sagittal view, and the uterus looks very distorted. Instead of being smooth and round, you can actually have a sense that the anterior lower portion is pulled up and stuck to the anterior abdominal wall. In the sagittal view, you have vagina, cervix, somewhat elongated, the bladder, and this is where the adhesion is. And no matter how big the bladder would get, it would just keep pushing up at the uterus and never cover the uterus to provide a sonographic window. These are CTs and a diagram to explain the problem that happens in transvaginal imaging in these patients. So in this axial image, the uterus is here, and this is the adhesion to the anterior abdominal wall. In a sagittal reformat, the cervix is elongated, the body of the uterus then sort of falls posteriorly, and you can actually see the small adhesion to the anterior abdominal wall. Imagine now if we put a transvaginal probe right here, and this is the section that we are able to image, the distance that we can see. The transvaginal image will predominantly show the cervix, and much of the body of the uterus will be well out of our field of view. So if I flip the CT image the way we look at ultrasound images, you can see that, and we put them side by side, on the transvaginal I have a wonderful view of the cervix, better than we usually see, but that unfortunately much of the uterus is poorly imaged because this is the part that's fallen back. This is another patient. She had prior cesarean sections, and the position of the uterus is not distorted, but the person scanning was concerned that there was a round mass in the anterior uterus and considered that this may have been a myoma. However, if you look carefully, this is the location of the scar from the cesarean section right here. And sometimes because it is pulled up, it causes some distortion in the adjacent myometrium and makes it look like a round mass, which can be mistaken as a myoma. Another patient with prior C-section, the question is there some sort of odd endometrial abnormality? The endometrium is seen nicely here and is smooth, and right here it looks a little thicker and perhaps a little irregular. Could this be a polyp? These are Nabothean cysts. In transverse, you have this odd sort of triangular shape of the endometrium at this location. And once you realize that this is the site of the cesarean section scar, it's clear that the endometrium is being pulled into the site of the scar where there is thinning and irregularity of the overlying myometrium. So there's nothing intrinsically wrong with the endometrium, it's just pulled and tethered into the scar. To take this one step further, if there is endometrium in the scar, then clearly blood could accumulate in that region related to menses or potentially to some other procedures. And this blood can accumulate and be in this location as a reservoir, providing a means for or causing intermenstrual bleeding. These are two separate patients, and you can see the blood in the lower endometrial cavity and a little bit in the cervix, extending to the cesarean section scar. Here's another patient. You can see the blood almost seems to extend all the way through the myometrium to the serosal edge. Both of these patients, when asked, gave a history of spotting after menses. They complained of the menses being too prolonged. Depending on the position of the uterus, you have to look in different places. Here's the retroverted retroflexed uterus, and so the scar is over here. This is the transvaginal view of that patient, and there's fluid in the scar, which is here, and the patient also had bleeding after menses. This patient came with a history of very heavy menses and some intermenstrual bleeding. On transvaginal imaging, we had a hard time seeing the endometrium because there seemed to be a large mass with shadowing in this region. And so the patient came to have a sonohysterogram. Fluid was instilled into the endometrial cavity via a catheter, and you can see very nicely outlined this fairly almost completely intracavitary myoma. In addition, however, the fluid also filled this little niche or scar from the prior cesarean section during the sonohysterogram.